Thanks so much. It's absolutely thrilling to be here. I think this is the third year I've tried to get here, and third time, I guess, is the charm. So it's fun being here and seeing the amazing work that people are doing and catching up with old friends and meeting new people. It's really terrific. You know, as I was getting ready for this talk, we had a little conversation with Scutch about what was it that he was hoping I would talk about. What was it that he was hoping that I would do here? And the answer kind of surprised me, which is, could I explain how I got into this field? So I've been thinking about that and wondering, you know, sort of how it was that I did get into this field. And I guess I had to conclude that I've probably always been there. I just didn't know it had a name until a couple of years ago. And thanks to Scutch and RWJ and lots of other people who have been blazing this trail, it really has a name and it has a direction, and is developing, I think, really incredibly. But if I go back and think about, well, how did I get into this? I have to go pretty far back. And I probably have to go back to high school when I was a pretty wayward kid. And I ended up getting adopted by an infectious disease pediatrician at the University of Connecticut. And she worked in the county hospital there. She took me on rounds with her to see, and there was a kid who was in one of those old metal cribs and who was seizing. And she was called because there was a question of whether the kid had meningitis, and she was an infectious disease doc. The kid didn't have meningitis, the kid had lead poisoning. And she decided, and had decided, that lead poisoning was really the most serious health problem for children in that community, and that she was going to do something about it. So she had me go around all the housing projects, drawing blood and collecting urine samples and collecting paint chips to sort of map out and look at what was the epidemiology of lead poisoning in Hartford. And then she came to terms with the fact that a major source of lead exposure was lead in gasoline at the time. And she took me with her to the state capitol when she testified about the importance of getting lead out of gasoline. I didn't really think much about the really profound influence of this very early mentor. But it was really clear that she was able to connect what she was seeing at the bedside to what she was seeing in her community, to what she was seeing in policy, and understood sort of a role of research in addressing some of these really complex systems problems at the time. I'm sad to say that when I go back to Hartford to visit my mom, the lead belt is still there. Multiple generations of people working in public health have tried to do something about this. I could probably still tell you the inside of every one of those houses and tell you the lead levels of kids who used to live there. And sadly, I'd probably still be right. So that's one of the really big challenges I think that we face. So then I fast forward a number of years to being a relatively young faculty at the University of Minnesota. And as you heard from Paul's introduction, I've always split my time one way or another between practicing primary care and doing research one kind or another. And I was trained in health services research as a discipline, I guess. And sort of a couple years into being a new faculty member, and I was in clinic one morning, and I usually did clinic in the morning, and then I went over to the School of Public Health in the afternoon and had this kind of double life as such. And a woman came in who had missed maybe her last 4 or 5 appointments, and I had a really, really busy schedule. I was way overbooked, and I had sort of counted on her not showing up again, but there she was. And I was originally sort of annoyed that, you know, she was coming in after having missed multiple appointments. And I went in the room, and she was there with a little 6-year-old kid in tow, and her blood pressure was just off the wall. And I sat down and I sort of said, "So what's up?" And she proceeded to tell me that her daughter, who lived in Chicago, was incarcerated for crack cocaine, and she had her 6-year-old grandson with her. And since her grandson had come to live with her, He'd been just having uncontrolled asthma and was up most nights having asthma attacks, and multiple times a week she was in the emergency room with him getting his asthma treated, but he had no health insurance. And so, you know, taking care of her grandson and being in the emergency room all night and dealing with him during the day, she just couldn't get her medicine refilled and she just couldn't get to clinic. And she hoped I'd understand. It was pretty easy to understand. I knew what to do. I gave her some blood pressure medicine. I brought her kid down the grandkid down the hall to the pediatrics clinic. I got him signed up for health insurance because then we had Minnesota Care, a precursor to a lot of other health reform. So that was pretty straightforward to do. And I sat down to write my note, and I was paralyzed. I found that I couldn't write my note. I had a bunch more other patients I needed to see, but I just sat there and I couldn't write. I couldn't go on and see the next patient. And I just kept saying to myself, I can't keep doing this. I can't keep doing this. I can't keep doing this. And I can't help my patients get better unless I help my community get better. Then I started to really wonder, well, what does it mean to help my community get better? And I didn't really know. But I know that over a very short period of time, I abandoned most of the research projects that I'd been involved in, most of which were involving asking and answering questions that probably didn't matter at the end of the day, but they were doable with large data sets. And I really began to take on issues in my community, to learn from my community about what was making it sick and how to make it better. And it was a real turning point for me in my own career. It's really about, I think, those sort of public health systems and services. So that's why I say I probably got into this field before it had a name, before it had an identity. Most of my fellow faculty members either thought or knew I was just nuts, but they couldn't really understand why I was sort of abandoning a seemingly successful career track for something that seemed to them pretty risky, pretty unproven. And, you know, what's really all this community stuff about anyway? It's not really research. And why do you care about the health department or the public health system? Because that's not really research. That's just soft stuff. So that was a struggle then. I suspect that it's a struggle that many of you share or encounter even now as you do your work. But at least the field now has a name and a direction and is getting some good methods and some good standards, and I think that's a great development. So that's my story, and I'm sticking to it. But let me share with you a little bit about what I'm doing now. So I have, since the beginning of the Obama administration, or since 6 months into it really, served as the Assistant Secretary for Preparedness and Response at HHS. And this is a role and responsibility that I sort of view sort of brings together lots of different strands in my life, mostly because it sort of sits right at that crossroads of taking care of individuals, of medicine, and of public health. And I view my office as a place where those two sort of strands of health really need to come together in one way or another. You know, our role at the end of the day is to ensure that the nation is prepared for and can optimally respond to and recover from public health emergencies, particularly large ones. A year ago, December, our office issued the first ever National Health Security Strategy, which really defines health security and provides a framework for the nation going forward. And the key themes of that are really listed on this slide, but I want to sort of focus on three aspects of that. You know, first is that this is a national strategy, not a federal strategy. And so there are things in there and actions and activities that all parts of society really need to undertake if we're going to achieve this goal. Second is this theme of resilient communities, that we all know that individuals and communities that are less vulnerable will fare better and recover faster in the face of adversity, in the face of public health emergencies. So thinking about what does it mean to build a resilient community or to have a resilient community, in this case in the name of preparedness, but it's probably good for us overall. And then finally, sort of strengthening health and emergency response capabilities, absolutely core to our mission and what it is that we need to do. Some of the themes that you all in this field think about and worry a lot about in terms of measurement and accountability, return on investment, et cetera, are central to the work that we do. But at the end of the day, it's multiple, I'd say, sort of complex adaptive systems that really need to come together if we're going to be prepared and to be able to respond in the face of adversity.